Greetings, friends, enemies. Here's Chapter 9 on Doctor-Patient Interaction. Don't be weirded out by the slide saying 13th edition. This is because, well, it's an old slide I've had. I've added a little bit to it to match the 14th edition, which is what I've been doing with, well, really all of the slides throughout the semester, in case you weren't aware. Alright. So, what is this chapter? What is it about? It's really kind of the second act of our discussion of the sick role from Parsons, right? Parsons talked about the way individuals are expected to act, how they conceptualize illness, how they conceptualize health, all these different things, but focusing on the patient, right? This is the other side of the coin. We're talking about the doctors, the physicians. And the sick role does detail these obligations of physicians as well, although in our previous chapter really just talked about the patients. So we've already established that patients are expected to cooperate with doctors. They're trying to expect to get better, try to have some kind of understanding of their illness, and so on and so forth. Now, doctors attempt to return patients. The expectation is that doctors will attempt to return patients to as normal a level of functioning as possible. Right? This is the deal. Right? We listen to the doctors, we do what they say. Hopefully that means we get better. And when we're talking about acute illnesses, usually that does work. It gets a little bit different when we start talking about chronic illnesses, but we'll get to that in a few slides. Alright, the chapter starts talking off about the medical decision rule, right, which is the guiding principle behind everyday medical practice. And next slide really kind of gives you the textbook definition of it. But the idea here is just that, they're doctors, right? So what are they going to do? They're going to doctor. It's the idea that for a person who has only a hammer, all problems appear to be nails, right? These folks are physicians, so they're going to look for physical problems. They're going to try to impute or even, see illness maybe where it actually isn't. They'd rather err in that direction than to err in the other direction, which is to miss an illness and then have somebody potentially die or something, get even sicker. So, now this has a lot of wide-ranging consequences. I'm sure you guys can probably sit there if your wheels are turning. You'll understand that this idea that sometimes people get overtreated is one of the reasons why we have expanding costs. Right, our healthcare costs keep going up year after year after year, and one of the reasons for it is this kind of guiding principle. And again, it's not a bad principle; it's probably a principle we're all fairly comfortable with. Heck, I'd rather my doctor give me antibiotics unnecessarily than not give them to me and have me die of typhoid or something, right? I'd rather, deal with whatever problems with the antibiotic resistance I'd have down the road. At least I get to live that long, right? That's one of those, in an imperfect world, you pick an imperfect solution. But of course, one of the consequences of that is, well, I already talked about antibiotic resistance, but also these costs are expensive. These treatments are expensive. Every time you fall down and wang your head, right, if you go to the ER, what are they going to do? Well, they're going to do a CAT scan, right? Even if you're not showing any real signs of concussion or brain bleed or anything like that, they're still going to run that CAT scan. Why? Because if on the off chance that you did rupture a vessel and they sent you home and you just bled into your skull overnight, you would wake up, well, dead. Because you wouldn't wake up, right? So you get the idea. So that is the idea here. The doctors are trying to, again, help their patients. They don't want to miss anything. All right, that being said, there are different theories out there about how doctors and patients interact. And that's what this chapter is all about, mostly. We have the Saz, I think that's how you pronounce that, and Hollander, who talk about the interaction that doctors have with their physicians being related to the severity of the symptoms. Now, this one's pretty intuitive, right? I'm not going to read the slide to you. But the idea is that, when you're seriously ill, you get a car wreck or something like that, you're wheeled into the ER, you're not asking a lot of questions, right? You're not going to be like, yes, but does that antibiotic contain egg or mercury or anything? You're not going to get into that, right? Like, yes, but I think I read somewhere this other antibiotic is, but not going to get into this stuff. You're just going to let them do what they do, right? You're about to die. They know how to fix you. You just let it go, right? So you're helpless, so that's how it goes. That's the activity-passivity model. The doctors are active. You're passive. That's how it goes. Interestingly enough, this is how people often behaved, doctors and patients interacted for all medical issues, 50 years ago, right? It was always this doctor was the learned, professional. You knew nothing. They told you what to do. You did it, and there you go. There wasn't a whole lot of questioning. Now that's obviously changed, but This activity-passivity model in modern day refers to usually folks who are, in fact, helpless. Then we get to the guidance cooperation model, which is kind of the next step up, where you're not dying necessarily. You didn't just get into a car wreck. You didn't get, a tree didn't fall on you or anything. This is you have an acute or often infectious illness. So let's think, strep throat, ear infection, sinusitis, that kind of stuff, right? It sucks. You're in pain. It's no good. You're in the clinic or the care spot or wherever it is you went to go get well. And they know, what's going on, right? You can cooperate with the physician, but the physician's still making the decisions, right? They're still looking at you like, yep, you have this. They do a swab of your throat, like, yep, came back positive for strep. Here's your amoxicillin. Off you go, right? You're not going to sit there and debate them, right? Like, are you sure amoxicillin is the right one? You're not going to do that. You're like, yeah, I feel like crap. That sounds like an antibiotic. It's only $7 at Publix. We're on this, right? That's the guidance cooperation. So, here, there, the doctors give you guidance, being like, okay, get plenty of fluids, get plenty of rest, take these pills, finish your antibiotics, you'll feel better. And you go, yes, doctor, and you cooperate, right? That's guidance cooperation. Then we get to mutual participation, right? Now, we're not dealing with infectious stuff anymore, and kind of like, acute calamity. This is where you're managing a chronic illness. This is a whole different ballgame, right? Here, the patient's actually working with the doctor as a full participant in controlling the affliction. Because that's really how chronic diseases work. There's no cure. It's really a question of management. And so it comes down to, health behaviors. Yes, medications, but how medications are used. The degree of discomfort that a patient is willing to put up with in order to maybe preserve some function in some organ, on and on it goes, right? It's more of a back and forth because that's how management of chronic illnesses works. Because there's no cure; it's just management, and everybody's a little bit idiosyncratic. So this back and forth is how that happens. Now, this theory, go back on the slide here. The SAS and Hollander is pretty intuitive, right? You probably figure, yeah, that makes sense. That sounds like about how that works. Now, there are other models of interaction that are out there, but that's the one that we probably can walk forward with here. But we also have Hayes and Bautista, who are really talking about when a patient's not satisfied with the treatment, right? The previous one we were talking about here, the SAS and Hollander, that's kind of a general model. This is more of a specific one for when you're not happy with what's going on. And it talks about the interaction of patient and doctor as a negotiation. And really, there's actually an entire, wing of sociology that looks at all social actions as negotiations. So that's not really so shocking that it kind of makes its way into this particular subdiscipline of medical sociology. Now, the model here, again, is limited to patients who aren't satisfied with treatment and want to persuade the doctor to change it. So something, you went there, they ordered a set of treatments that didn't work out, and you want them to do something else. Now, these models of interaction, or ways of interacting, I should say, are also influenced by other stuff, right? We already have the severity, symptoms, and satisfactory treatment, right? We have those covered in the previous slides. But also we have social class, age, and education, right? Now, before I move on with this, I would like to point out that this isn't unique to doctors and patients, right? How people interact is often influenced by social class, age, and education. More to the point, differences between the people interacting in terms of social class, age, and education. So, when we go through these things, I'm not trying to say that doctors are any more or less, say, and gender should be in there too, by the way, they're any more ageist or sexist or classist or anything like that than the general population. What I'm saying is the doctors are like the rest of us. They're just as racist and sexist and all these different things as the general population, right? They're not special in that sense. They're special in the sense that they can do doctoring things. That's special. But as far as being different than the rest of the population and more socially, egalitarian or aware, that's certainly not the case. They're people like the rest of us. Now we have mutual participation. Again, this is our normative model. The idea being that both actors are trying to reach a goal. Yeah. So what are we getting at with all this? Well, it's not so much, the social class, age, education, gender, race, all that other good stuff. It's not so much that doctors are necessarily attempting to treat people differently as because of it, like some kind of cartoon supervillain. But what it can do is it can cause misunderstandings in communication. And as a result in poorer outcomes for more marginalized groups. And so we talk here about information being an important therapeutic tool in medical situations because, well, it reduces uncertainty, it provides the basis for action, and it strengthens the physician-patient relationship. The idea here is that, when you go to the doctor and they tell you, okay, this is what's, they give you orders for what you need to do, it's nice to be told what's going on, right? You walk in, yeah, I have, I'm bleeding out of my eye sockets. What is this? And what is going on here? It'd be nice if somebody told you, what this was. Instead, they just rip off a prescription and hand it to you, and off you go. And this lack of this ability to reduce uncertainty and provide the basis for action because you have an understanding of what's happening, you have a relationship with the doctor, this does have this therapeutic value. Makes the patients, frankly, much more likely to be compliant to doctor orders, which is really the name of the game when it comes to positive outcomes. Now, there are still instances, of course, of misunderstanding in communication or times when doctors withhold information. This certainly still occurs. And again, it's not entirely uncommon. And a lot of times what you see is families who are trying to, they'll try to get information on just about anybody in the medical staff, and oftentimes it falls to the nurses who, just tip our caps to them and thank them for everything they do, putting up with everybody. All right, so we'll talk about social class here. Doctors from upper middle class backgrounds will talk more, right? Just like people from upper middle class backgrounds talk more. I myself, I grew up a working class kid. I'm now an upper middle class kid, and I can tell you the communication patterns are wildly different. You hang out at a bar in the old neighborhood. There's more yelling, I suppose, but not as much talking. There's no deep conversations about whatever the heck, right? You go somewhere a little more high class, a little more Tony, if you will. Yeah, there's plenty of conversation going on, lots of communication, lots of sharing, if you will, which is good, it's healthy and all that, but it is certainly different, right? And so doctors who have come from that background of talking more are going to be more likely to talk. Working class doctors, again, they're doctoring just as well as their upper middle class counterparts, but they just aren't that kind of person, right? You get the idea here. Now, where it does get a little bit sticky is we note here that patients from a higher class position tend to get more information for a couple of reasons. One, the doctor may assume that they can actually understand it, but the other part is they probably demand it. I would add that in there too. People go up the social class ladder. The further up the social class ladder you go, the more likely somebody is to ask to talk to the manager, right? So it's the same thing with a doctor. So the upper middle class folks, if they aren't sure about something, they're more than happy to stop everything and make people explain it to them. So again, it's one of those things that class has privileges, right? Now, the greater the dissimilarity between the patient and the doctor in social class, the increased likelihood for miscommunication. And again, it's not unique to doctors. It's for everybody, right? Of course, it has greater consequences when it's the doctor-patient interaction that may be breaking down. Now, patients and doctors that share similar class also share similar communication styles. That's how it goes. And again, if those of you who are sociology majors have probably been introduced to this idea, but yeah, the one social class does have this very profound impact on how you see the world, how you approach the world, how you interact with the world, and that includes the way you communicate. And again, it's not that one communication style is superior to another, they're just different. Now look at the gender. And again, what happens in the greater society happens in the doctor's office as well. Now, the women's health movement, that has been active for decades now, has sought to combat sexual discrimination in medicine, which again is really a matter of fact. It's not a perceived thing. If you look at the actual, there's scads of research out here that backs up that historically women have had short end of the stick when it comes to medical treatment. And again, it's because medicine isn't somehow separate and above the rest of society. It's just what it is. It's part of all the rest of us. And so, sexist attitudes and behavior towards women, patients, and health workers is something that these folks have been trying to address. The lack of sensitivity to the needs and complaints of women. And they give you an example here. There's lots of historical ones, but this is probably the more recent one that was kind of a big deal. I want to say 10 years ago, 15 years ago, they started really writing a lot of papers about this, when they had this tendency of male physicians to misdiagnose heart attacks in women. Because the idea is that doctors always assumed that estrogen protected women from heart disease until they hit menopause and then estrogen levels dropped, and then they could develop heart disease, right? That was always the assumption. So whenever women came in complaining of heart troubles, they just assumed it was anxiety or some kind of lady problems, stomach problems or lady parts or whatever, right? Very dismissive. And again, it's not sexist in a mean, awful, cruel way. It's more of a paternalistic sexism, or what do you want to call it? The benevolent sexism even. It still has terrible outcomes. These women were not getting treated for their heart problems and died prematurely, and that's a problem. But again, it was all part of this gendered worldview that the physicians held. And again, we're talking about historically, physicians have been a field that has, especially cardiologists, that have been dominated by men. So you have these men, largely from upper middle class backgrounds, who are treating women from all walks of life. But those who are likely to have heart problems when they're young are probably going to be lower class folks. So you have women, they're lower class. So you can see how the communication between upper middle class white guy, lower class or working class minority woman, again, there's going to be a breakdown of communication there. At least historically there certainly has been. And that's why now they put folks through classes to try to combat that. Let's start talking about women physicians, which are becoming much more common. Women entering medical school are a much more common thing now. I think actually shortly, or either may have even already happened, there's more women applying to medical schools or being accepted to medical schools than men. That said, there's still face problems being recognized as equal colleagues by male physicians and as quote-unquote real doctors by male patients. They note here that the top academic posts in medical schools are still overwhelmingly male, even with this change in enrollment and gender makeup of graduating physicians. Also, we start talking about specialties. There's specialties that are kind of divided up into male specialties and feminine specialties. This whole idea of a gendered hierarchy of workforce, again, this is a very common theme in U.S. society, and sociologists have been talking about this for a while, not just in medicine, but in everything else. Male jobs and female jobs, right? The male jobs are valued more, the female jobs, quote-unquote female jobs, are less valued, and on it goes. And it transcends into medicine. You have things like, what do they have here? Surgery, internal medicine. These are, masculine kinds of things. Soft specialties would be like OBGYNs and pediatrics, right? And women who enter these more masculine specialties, it's not that these institutions have somehow become more accepting of women necessarily, but the women have figured out how to adopt more masculine traits in order to be more successful in these schools, in these colleges. And so that's how this plays out. Now, in case you needed to see it, I'll go and put the line on the slide. Men and women physicians are similar in terms of diagnostic and therapeutic skills, so don't worry. You can't determine whether or not you're going to die based on the gender of your physician. Don't sweat it. The skills are all the same, but the specialties that folks go into are very gendered, and a lot of times this has to do with things that are unrelated to skill or ability. It's more, how do you want to put it, socialization. And again, with the socialization, female physicians tend to be, again, like female people in general, more empathetic, egalitarian in their relationships, respectful of concerns, responsive to psychosocial difficulties, easier to be around, right? Now, it's not just class and gender, there's lots of other stuff too. We talked about cultural differences in communication. And again, modern day medical practice, as we know it, is provided within what we call the context of what we call middle class norms, right? We believe in science. We believe in the application of sophisticated technology. We believe in the cooperation with physicians, right? That's a middle class. These are middle class norms. Now, patients that don't share these middle class norms are often going to be at odds with the medical service providers, right? Lower class folks, minority immigrant groups, these folks are much more likely to have misunderstandings and difficult interactions with doctors. because doctors aren't going to look. Burning sage isn't something doctors are going to recommend for clearing up bronchitis, right? It's not going to be a question of prayers or honey in dishes or any of these other cultural beliefs that people have. It's going to be very technological, very scientific, sciencey, and a very ardent belief in it, right? And again, that set of beliefs is a very middle class, Anglo-American kind of belief. Not everybody believes this around the world. Heck, not everybody believes it here. So, as a result, we do end up again with some of these communication breakdowns. And physicians, to be successful in treating everybody, are going to have to understand that this is coming and how to work through it and work around it. Because the end goal is this. We want patient compliance, right? That's what we need. We need them to do what we tell them to do in order for them to get better. When you go to see the physician, you don't just walk in, he doesn't wave a wand, and all of a sudden you're cured, right? No, they give you a set of medications, instructions, therapies, whatever it is, and then you're expected to go do it. And that expectation, and we call that compliance. We expect compliance to, and it requires, first of all, that the patient understands what you're asking them, right? That's probably the first one. So the very, very fundamental function of communication, which is, convey instructions, needs to be understood. But there's also other things here. Other things can influence whether or not people are going to be compliant. Their motivation to be healthy. We all like to think that some folks really want to be completely healthy, but apparently that's an assumption. It's not necessarily an empirical fact. There's a perceived, whether or not people perceive themselves as vulnerable to an illness, right? No, nobody in my family gets cancer, so I'm just going to keep on smoking, right? Again, that's kind of magical thinking. Patient compliance would be that you stop smoking. But you get the idea here, and it kind of goes on here. Personal control, effective communication. One that I always like is the effectiveness of the treatment. People comply when they see the treatment working, right? Things work, like, oh yeah, it's like you start a particular diet, whatever it is, right? Ketogenic is a popular one now, or macrobiotic, or whatever it is you're into. People start it, and all of a sudden they lose, say 10 pounds, lose just water weight, whatever. They lose 10 pounds in the first week. Like, oh my God, I'm going to stay on this diet right now. Next thing you know, they're living on, eating things that don't cast a shadow or something like that. The previous success will beget future success. All of these things kind of go into a pot that create this, what we call patient compliance. Now, bottom line, effective communication is really what this chapter is really all about here, right? These things are harder to deal with, right? These things are kind of situation by situation. But physicians and healthcare workers in general can impact effective communication. So what does the future hold? Well, the first one is this trend toward consumerism. And really, it's not necessarily the patients so much that are pushing towards consumerism. It's the whole healthcare system. We want to make informed choices about the services available. We know what people charge, who's good, who's bad. We kind of choose our physicians, our providers. And we don't want to be treated as inferior. We want to be seen as equals by our physicians, which I'm sure annoys them to no end. Which marks a shift away from what I talked about earlier, the traditional model of interaction, which characterized Parsons' sick role. This is pretty more the passive-active approach, right? You're passive, they're active, and that's how it works. I say I mean patient. The patient is passive, the doctor is active. There you go. Now, the increased importance of third-party payers and monitoring and limiting doctor autonomy is still certainly in play here. They made a stab at health insurance reform under the Obama administration. Seems to have been largely repealed at this point. That's for another chapter. But no matter how you slice it, people only get services that the insurance company is willing to pay for. So that's also part of our future with all of this. It's only become more so unless insurance companies are somehow eliminated from the decision-making process. I'm not hopeful. Of course, there's new technology, right? The internets. It's not just for cats. It's also for changing how people interact with the healthcare system. Now, it can be bad, and it can be good, right? You have a major source of easily accessible medical information. Of course, every time I do it, I end up with, I'm convinced I either have monkeypox or I'm pregnant or something along those lines. And I'm sure doctors love it when you go in there with your WebMD printouts telling them exactly what you think they have. But on the other side, though, it can give you some important things, especially when we start talking about things like electronic support groups. where people who have, say, like a shared chronic disease, or children with developmental disabilities and these kinds of things, it allows for people to connect where they wouldn't be able to, and they can share stories and support and resources and these kinds of things. That's a very good thing. Also, the internet's can provide the framework for things like electronic monitoring devices. You can talk to physicians via email or teleconferencing. My personal favorite, prescription drugs ordered electronically. Sit down kids will tell you a tale of the olden days, which is when you went to the doctor, they give you a prescription. It's actually a piece of paper. They write a piece of paper and they sign it and write what you're supposed to get. They write the name on it, they hand it to you, and off you went. You guys are probably like, wow, that sounds really quaint and old-fashioned. Because now, how does it work? I love it how it works now. You go there, they write the prescription, they punch it into the computer, boom. It's already sent to the drugstore. By the time you get out of your doctor's office, get paid up at the front desk, and get over to CVS or Walgreens, wherever you're going, it's there. It's awesome. It used to take hours. Not so much anymore. Now we have more drugs becoming available in a variety of forms: pills, injections, patches, nasal sprays. Some things that used to be, you could only get them in the form of infusions in a hospital. Now you can do them at home. Again, that's new technology. Of course, robots. Can't forget about the robots. Robotic surgeries are a thing now. And of course, genetics. We'll finish off our conversation with this. Genetics. The sociology of genetics really examines the social use, the control of information, the risks, and the ethics of genetic research. Right? Now, there's controversies surrounding a lot of this stuff. Genetic testing for diseases, prenatal genetic testing, human cloning, on it goes. And again, all of it boils down to a few central concerns, right? The concerns are, related to the individuals being used in the studies, their rights, as well as the ramifications of having some of this information be available when historically it never has been. So, what I'm getting at here is, this genetic testing can make it possible to learn somebody's likely health future that the person doesn't even really know, right? Which, while it's helpful for the individual, you can see how maybe that's not so great in terms of, say, health insurance premiums. Your genetic tick and time bomb for expensive services. That's one thing for you to know, but if your health insurance company knows that, man, that's bad news for you, right? You're probably not going to be able to get any life insurance, so on and so forth, which, again, it may seem fair, but I would argue that 20 years ago, that wouldn't have been the case. You would have been able to get the same things everybody else could have gotten. So it's bad news. So you almost don't want to do it just because that information's out there. They could use it against you. They have the example of the Havasupai Indians, which is actually a very interesting story. I don't know how much of your book goes into it. But this, they set out to find out markers for diabetes, right? The idea being that diabetes isn't solely the result of people's health behaviors. It can also be largely impacted by genetic markers. Now, there's a big scandal about all of it. They're about informed consent with these native folks that gave these blood samples. There's questions about whether or not the study was supposed to be for diabetes, but some folks argued that they were actually trying to find markers for schizophrenia, and it was a big hullabaloo as far as research ethics goes. So,